Sure, I can, yeah.
I've had several people with it, and people who were yes, all of the analysts have said that we couldn't do the video because that's copyrighted. They make a big stink about it. Give it a couple more minutes. So, yeah, sorry I didn't set up tissues or tell anybody to bring tissues. It can be a tearjerker. Alright, so the way we were gonna do the panel discussion is just kind of, go through each, there's kind of been common questions that people have for each of the different, in the specialties that we have here. So we're going to just kind of ask questions of each of those. Maybe the first time I ask the question, the panelists, they have to say their name and what their specialty is. And again, in that program, you can read all about the panelists and what they do and how they're trying to help people and advocate more for endometriosis. So we will start with. Okay. Oh, maybe we still have people. Cool. We're doing surprisingly fabulous on time. So when you go to answer the question, just go down the line. Yeah, just go down the line. What's that? Okay, so we'll just quickly go down the line because it makes more sense to do that. So we'll start with Marcia, and she would like to just kind of introduce herself and what her role is with endometriosis. And a couple people have asked, all the participants have agreed that if you wanted to record part of this, that's okay from the panel discussion. We simply couldn't do that from the video.
Sure, let me just stand up so you can all see me. My name is Marcia Torres, and I am a health and wellness coach. And my role here is just to support every single woman that goes through this. I am actually somebody that went through this, and it was really hard for me through all the years just not to know what was going on with me. I got a lot of miscarriages, and the only thing that doctors told me is like, your uterus is hostile to have a baby. And that's all I kept hearing. So it was hard. And I'm here to support and just help the guy. A lot of times doctors, give us instructions and how to check the diet, you have to do exercise. And then we leave it in the office and we don't know where to start. Because it's all about changing habits in our lives. So I am here to support, guide you in that path. And thank you, doctor, for hosting this. This is an amazing program for all of us to create this awareness. Thank you, everybody.
So I'm Raquel. Again, I'm a pelvic floor physical therapist. I do have a private practice here in Buffalo, a Droyer for PT, and I see everything for pelvic health. A lot of times the cases that I'm focusing in on are going to be those chronic pain, endometriosis, some of those other conditions that whoever that radio person was said are just garbage diagnosis and don't really exist. Interstitial cystitis, IBS, endometriosis, chronic pain. Those are kind of the things that I'm looking at and trying to help people before, after, during surgery. So how can we, as the video pointed out, and I think some of the panelists are going to talk about, how do we know excision, we know getting it out of the body is the best thing that we can do for it, but what about the rest of the body? What is the body left with? Where are tensions and troubles that are left after your body's been going through this for so long? And so that's one of the things I'm really trying to help is how do we get your body to be the best body that it can be where it is right now.
I'm the Burns of a minimally invasive gynecologic specialist at the University of Rochester.
We are an excision only.
That is true.
Hi guys, my name is Shai. I am a certified sex therapist, ASAP, also therapist, but I specialize in sexuality, relation, and trauma. So anything in between sex, desire, relationship, lack of, again, before surgeries, after 18 and above, as well as couples, and the larger impact of the disease on partners and other family members. So that's what I'm going to talk today.
Hi, I'm Stacy. I do acupuncture and traditional Chinese medicine. I have a practice in Lockport, New York, so we're in Niagara County. Basically, traditional Chinese medicine is just a completely different system of looking at the body. We look at the body constitution. So I have a general practice, so I treat patients of all different issues and diseases and things, but I have a large part of fertility in my practice. And so we work a lot with patients, again, before, during, and after different treatments, surgeries, IUIs, IVF protocols. So not only acupuncture, but traditional Chinese medicine is really focused on the whole body. So it really speaks to that, what's going on and what can we do to support the whole person rather than just the disease that we're coming in with.
Well, why don't we, since we were talking with Stacy, let's start with Stacy. How can acupuncture help with the pain and symptoms of endometriosis?
So I always tell patients, really what I do is traditional Chinese medicine, but acupuncture is usually what people think of when they come to us. So acupuncture itself is really helpful for pain of any kind. We treat a lot of acute and chronic pain, but when it comes to abdominal pain, due to various reasons, endo being a big one, acupuncture is really great at calming the nervous system. It helps with blood flow to the whole abdomen, uterus, and ovaries. It can release the endogenous opioids or natural painkillers, and it has a very anti-inflammatory effect on the body with creating circulation. So I would say that's the biggest way that acupuncture helps with pain management.
Thank you. Shai, what are biopsychosocial factors that impact clients with endometriosis in terms of their libido or sexual desire?
So I just want to make sure that everyone knows what is libido. But this is not like the first step. So this is kind of if I'm turning, if I'm interested, if I have a desire to be sexually intimate with myself or with other partners. So it's more arousal in context. It does not if I'm turned on or turned off. It's more if I'm interested. Just like a side note. So when I work with clients with endo, actually with everyone that have any kind of pain disorder, I like to explore what are the bio. So bio is kind of clear from the movie, it's more the medical side of that I cannot really help in that aspect. It's good to give the name and identify all the biological factors and your side of that. If they come and talk about the surgeries, pain, medication they take, physical issues, etc. And then we're doing a lot of psychological, so it's body image. I don't like my body has been changed, scarred, self-esteem, trauma, a lot of pain, trauma, mental health, shield, and to protect myself, I hold pleasure. So it's a lot learn about all the psychological factors that impact the desire itself, that decrease me wanting to be intimate myself with someone else. It can be life transition before surgery, after surgery, so it can be explored the psychological, and then I like to do the social, like the part in control with the partner to see if they understand, if they're educated, do I have enough support system? Maybe I don't have support system, so I'm alone. Maybe we took a bunch of loans, like this movie show right now, so we don't have money, so clearly we don't think about sexuality. So when we identify all the factors, it's easy for me and for the clients to kind of decrease each factors to increase the whole desire and a kind of bigger I recommend, even with yourself, just identify what are the biopsychosocial for myself impact by endo.
That's a really good point too, that I hadn't thought of, is just when you're under so much stress
Yeah.
from a financial standpoint, from so many things that would affect.
Kids, financial, if you
Yeah.
wanna have kids, he wants, actually, so it's, you can just identify, even with yourself, like, what currently, the biological, I feel we mainly talk about the biological, but there are mainly so many other factors that impact by endo, like I have pain, let's say I got the worst period right now, so clearly I cannot even think about something else right now. So if you give it a name, it's easier to treat and just kind of work on that factors and give the name. So, yes.
Thank you. So for our physicians, what do you suggest that people look for in a surgeon or a provider when they're looking for someone to treat endometriosis?
Sure. So I think that there's a lot of things. So I think obviously we would recommend someone who is fellowship trained, who is going to be able to perform an excisional surgery, and you also want someone who's going to talk to you about what they're going to do in a great amount of detail. You should be able to ask them questions like, how much of a surgery do you do? You know, what other parts of OB/GYN do you do? How often are you operating? What would you do if you found endometriosis on the diaphragm? What would you do if you found endometriosis on the rectum? What would you do if you found endometriosis on the appendix? People should be able to tell you for each one of those what their plan would be. And then you should feel comfortable with what that plan would be. And I think that kind of segues into beyond just, you know, I think we all want surgeons for any problem that we're going to have. So we want somebody who is going to be able to take care of the problem. But I also think that my recommendation would be someone that you feel comfortable with, who you think is going to be able to honor the goals that you have, because not everybody's goals are the same. And if your number one goal is that you want to have a pregnancy, then you want to have somebody who's going to, you know, leave your ovaries, make sure that your tubes are okay, are going to maintain the uterus. You want to make sure that your surgeon is on the same page with you and helping you reach what your goals are. Because it doesn't matter what our goals are. The thing that matters is getting you to where you want to be. And then of course, someone who's going to respond to your questions, somebody who's going to be there afterwards. Unfortunately, all surgeons have complications, and that's just that is unfortunately true. And you want somebody who, if there's a complication, is going to be there and is going to continue to take care of you and be responsible for the care that they provide.
You want a surgeon that has a good team working with them, even though Dr. Fox and I have both done a lot of training to be able to handle all of the types of endometriosis. We still work with colorectal surgeons, we still work with urologic surgeons, we work with cardiothoracic surgeons, because there are forms of endometriosis that are beyond the scope that we can handle independently. If you have someone who has a team that they're comfortable working with and they have a good, strong relationship with, you're in much better hands. And by talking about your desires, your wishes, your goals ahead of time, do you want us to deal with endometriosis on the level, or do you want us to document it, get all the information, and then talk to you about it to maybe decide if a second surgery down the road would be a better option for you? You don't want a surgeon that's going to make decisions while you're asleep. That's not our job. That's not our goal. Our goal is to support your wishes, your goals, and to help you achieve what is really in your best interests, and neither of us can make that decision for you.
One of the questions that I, as a physical therapist, would often be asked would be, what can pelvic floor physical therapy, or excuse me, how can pelvic floor physical therapy help me with the pain and symptoms of endometriosis? So again, endometriosis is not a condition that I can cure in any way. But I do know that when there's pain with intercourse, what do? You tense. When there's pain in general, what do? You tense. And sometimes that tension just stays in the body. And so that's one of my roles, is to help you learn how to have tools movement-wise. How can we get those bodies moving better? How can we get the muscles to relax? Because is your pain at this point coming from endometriosis or something internal, or is it because you're tensing up expecting the pain? And so we need to treat both of those. Oftentimes we see that it has a really great effect after surgery because before surgery, it's hard to get muscles to relax if you're still having the pain from endometriosis. But even to that end, we can have people coming in getting ready for surgery. How do I learn how to move a little bit better right after surgery? We know that within the first week is when adhesions kind of happen. Okay, well you probably aren't going to get into my office we might be able to, but you probably don't want to move a few days after surgery. So what could I teach you before the surgery to move yourself? In learning how to move, learning different breathing positions of the body that could get you moving enough to keep that scar tissue from maybe happening. So that's kind of what the role that I see is helping you walk through the physical aspect. How can we get your muscles to allow your body to do what it needs to do? And then once that endometriosis is under control with whatever means you use to control it, how do we get you back to whatever it is that you enjoy doing? Do we want to golf? Okay, well let's get the golfing muscles back again. Okay, so that's kind of what I see my boss. And then Marcia, how can a health and wellness coach assist individuals with endometriosis in making informed nutritional choices to help them manage their symptoms?
Thank you for that question. And how a health and wellness coach can actually assist in that matter is first and foremost creating awareness, right? Creating awareness about what is happening in our bodies. We feel bloated, we feel tired. So we want to understand what we are eating to make us feel that way. And then from there comes the education piece. What can we eat? Perhaps foods that are high in antioxidants, anti-inflammatories, good fats. And we need to know exactly what we're putting in the fats. Because you probably have heard a lot saying is we are what we eat. And that is absolutely true. So we can actually help to manage that pain. We can actually help to have a better lifestyle just by creating that awareness. And that's how we can help.
And I think that is sometimes that the other pieces is sometimes what we miss out on is, oh, I'm going to get that surgery, and then the surgery is going to take care of it. But if our body isn't in the best condition to heal from that surgery, if we're, do we think that eating broccoli is going to cure endo? No. But if your body's in a position that it has less inflammation in your body when you have the surgery, does that mean you're going to heal better from that surgery? Maybe. Does that mean you might not need another surgery down the road? Maybe. And so really that's what, Marcia with the health and wellness is guiding you through that, because we all know what we should be doing. We all know we should be eating fruits and vegetables and drinking enough, but sometimes you need somebody to help you through that process and a coach and a guide. Yeah.
And through that process, you create a better lifestyle for yourself, something that is permanent. Something that actually is going to stay with you, and you are just creating a better path for yourself and your family. So that's what we want to create. We want to create actually a steady lifestyle that you can enjoy.
All right, thank you. So headed back down to Stacy. What other forms of natural treatment options are used to help with the pain and symptoms of endometriosis?
So most acupuncturists will be not only trained in acupuncture, but a large majority of them are trained in herbal medicine as well. So we have access to just looking at a patient's constitution, looking what their diagnoses are, assessing them from our standpoint of diagnosis, and then choosing herbal formulas that fit that pattern for the patient. I will also say a large percentage of us will also do supplements, more from like a functional standpoint. So some acupuncturists are trained in reading your lab works and helping you decide which supplements or herbs might be appropriate for your body constitution. A lot of times we'll do at-home techniques with patients, so whether it be recommending lifestyle changes, like nutrition things, or just how you're eating, not just what you're eating, deep breathing exercises, more functional things, some may be more versed in herbal medicine, so every practitioner is slightly different, but we have a wide variety of tools on how we can treat patients.
And Shai, what strategies can be employed to enhance someone's sexual desire when they have endometriosis?
So the first is, and obvious, but I feel like it's sex education, like what kind of orgasm. Like maybe we cannot have vaginal orgasm for the next 5 months, 2 months, or 5 years or 10 years. So there are so many different of orgasms, sexuality, and kind of more explore and extend what is my own sexuality, and then what way I want to take, what route. Because probably maybe what I know not working for me right now because of pain, because of I don't know other problems that we have. So I like to explore first of all how much clients know, and then just like increase education and explore that with yourself or maybe with your partners. And communication, it's also can be obvious, but talk about that, not in bed. Don't wait till like 9 p.m. and say, you're not doing it. So I like to do like a business meeting. It can be business about like the condition right now. This is how I am this week. I call it like a business. If you work in a business, you have like this weekly meeting of how everyone's doing. So again, like take some time to educate your partner and assess how I feel and what's my boundaries. Explore boundaries again and consent. That's what I cannot do, but I can do something else. Or this is off the limit. Again, don't wait for 9 p.m. to say anything. Because most of people will do that. A lot of like increased arousal, like in general, I know it's really hard with people with usually feel on the slow. Just increase your arousal in general. Wear clothes that you like. Do things that make you feel playful. Bring some more joy, intentional joy to your life. Again, not just sexuality, but like research found when you're more aroused in general, you're gonna have more sexual desire. So it's a lot of work about how do I increase my overall arousal, how do I feel good in general, so I feel more connected to myself. Dating with yourself and with your partner. Again, we said like life stressors and money and kids. It can be even 5 minutes that I take this 5 minutes for myself or 5 minutes with my partner. Yeah, toys, masturbation toys. Again, your pain, but sometimes actually orgasm decrease pain. So it can be something to explore with. See, and maybe doctors will do it. And many of my clients would say that they feel less pain with orgasm. Again, each client is not like the medical recommendation, but it's something to explore maybe with your own doctor about that. Sensate focus, a lot of like emotional safe touch with your partner. So you can read about that as a non-genital touch. So you feel secure, you feel safe, with safety and emotional safety with your partner. And just kind of, I always tell people like, deal with that, not just with the medical aspect of the disease, but how I can feel better with that. So read books, watch TV, or maybe Netflix show that maybe will increase your arousal. And restore or anything else. So just work on kind of like prioritize the values of increased pleasure with that condition. So it's kind of like work with that, with books, educate, and podcast, and just be more involved with your own pleasure.
Thank you. And I really appreciate what you just said about the boundaries too, because I think when people that I do see people who are dispareuning or pain with intercourse very often, and they almost feel this need they have to try. That, well, I've got my significant other, I'll just grin and bear it. But finding some boundaries and being able to say yes to this, but no to that. And finding more things to be able to feel like you can do some things, but you don't have to force yourself to just sit there and grin and bear penetrative vaginal intercourse when you know it's going to be painful. I think that's really important. So to our medical provider, this is a big one. What do you do if you still have pain following an endometriosis surgery? Because unfortunately, not everybody gets to have the perfect endings that we did see in the video.
all of these mood symptoms, if you don't address those as well, the pain is not going to get as much as it could. So when you have a specialist that is truly taking an interest in you, they are going to ask you questions about your mental health. And they are going to be involved in, do you have a therapist? Do you have a psychiatrist? Do you need one? Because we really want to treat you as a whole person, not you as a physical body, not you as a biochemical set of signals going through your brain. We want to treat you as an individual.
Well, pain is isolating, and, we have good data that social support and support in your life really is helpful for pain. And it's the same thing, anxiety and depression do not cause pain. However, if you have anxiety and depression, it can make the experience of pain worse. And having pain can absolutely, it is scary to go through life and not know when the next time you're going to have a pain flare, the next time you're going to have to go to the emergency room. If you've had, emergency surgery from a ruptured endometrium, like we're being worried that's going to happen again. That is very, very hard. And people a lot of times need support. And so, our goal is always try to connect people to all the things that are going to help us tackle their pain and make their symptoms better.
I love it. And that actually does, in the program, I put a little something about the acronym SPACE, which is very similar to what you're saying, but this idea that you may not today be able to get rid of your pain, but maybe focus on one of the other things that influences pain. So if you are tired, your pain is going to feel worse. If you are in a bad mood, your pain is going to feel worse. If you aren't eating properly, getting the right energy, your pain will feel worse. If you, we use C as comprehension. When you understand what's happening, it takes away some of that fear, which can enhance the pain. So sometimes, right, you can't change the pain, but could you change something else that could be affecting it, just to make little bitty changes? Because every day is a different day. All right, so a very common one is, what would, for me, as a pelvic floor therapist, what would be some exercises you recommend for those with endometriosis? Certainly there are lots of them, but the first thing I put to every person is diaphragmatic breathing, belly breathing. We know that pain heightens our nervous system. We're like this. Well, how are our muscles going to relax when we're here? We know that doing diaphragmatic or belly breathing calms the nervous system. We know that doing diaphragmatic breathing helps lower blood pressure. We also know that doing diaphragmatic breathing, which is often referred to as belly breathing, I'm filling my belly with air. Now I'm getting a little movement through my pelvic organs. Is part of my pain because there's not good movement? If I could get better movement of my organs sliding and gliding on each other, could that decrease some of my pain? Is my pain because my pelvic floor muscles are doing this? And you have absolutely no idea how to relax them, because who knows that? Until you start trying to do it. But nobody thinks about their pelvic floor muscles until they stop working right. You're gonna have you haven't learned at a young age, this is how I relax pelvic floor. So diaphragmatic or belly breathing is a way to trick your system. As you inhale, when you take this nice big belly breath, I'm imagining that my abdomen is like a balloon and I'm filling up that balloon. The bottom of my balloon is my pelvic floor. And think of what happens to a balloon as you fill a balloon. The bottom expands down too, doesn't it? And so that's going to help relax the pelvic floor. Your brain will automatically tell those pelvic floor muscles, I need you to relax and lengthen. I need room for my organs to move as well. And so that's going to be the first thing, and then the biggest thing. And it doesn't happen often, but I will have people come back after day one just doing diaphragmatic breathing saying, holy crap, like it made a huge difference just breathing. So that's the first thing I start with. And then it's a lot of gentle stretches. When you're in pain isn't the time to be building strength in muscles, unless there's some strength problem that's causing more pain. Like if you're very weak in your hip and that causes you to hurt while you walk, okay, then maybe we're working on strengthening. But usually gentle movement? How do I stretch through my abdomen? How do I get more movement in this abdomen area so that it can stretch and relax? Stretching through, think of the adhesions maybe. So I often tell people, think of a scar that's on your knuckle. When you first get that scar, it won't move. But over time, if you keep moving it, that scar tissue softens and stretches out. We didn't get rid of the scar tissue, but we got it to move better, and we no longer have as many problems with that scar. And so we can think of that even with the abdomen. How could I get my abdomen to stretch and move more? Could I soften some of these adhesions that may be there? And then finally to Marcia, what role does goal setting play in managing endometriosis? And how can a health and wellness coach assist in this process?
And for this, I'm going to stand. Well, the first thing that we want to understand when it comes to goal setting is what is our priorities, what is stressing us, and how can we get there. When we get to understand that, then we can start thinking about, okay, what do I want to change? What is that I need to either increment or decrease in my life? And then from there, just getting those baby steps and just being very compassionate with ourselves. This is not a competition, it's an understanding why we're doing it. So if they have, the doctor has told us that we need to drink more water, and we have a hard time drinking water, I have listened to different clients that say, water is disgusting. I don't drink water. And you probably have heard that. Okay, understand why. And then if you want to add this in your life, what is the benefit to you? So when we really understand the benefit, what is behind that, well, it's going to be easier for us to accept and to try something. And we actually get to do it, we're going to be so happy that we want to do more. Because we know that we are changing something better for ourselves. We're changing to a better lifestyle. So goal setting is all about understanding the why and just doing those baby steps so we can reach that. It's not about large strides, but baby steps.
Thank you. All right, so now we've got a couple, I had posted on asking all of the different people following my channels and then within endometriosis groups, hey, what are some questions you would have for our panelists? So I will just ask the question, and then whoever feels like they can answer, please just shout out. I want to know more about how to handle menopause with endometriosis.
So, this is always tough because one of the sort of myths that is often perpetuated is this idea that like we're gonna get to menopause and it's all gonna go away, and that's probably not true. In menopause, some people do find that some of their symptoms improve in some of the same ways that some people's symptoms improve when they're on hormonal suppression or when they're pregnant, and it's just because these are like low estrogen states. However, it does not make disease or scarring or fibrosis spontaneously disappear. And the same for people who have endometriomas. It doesn't make the endometriomas necessarily go away either. And those are sometimes people who we need to continue to surveil. And so my hope for everyone is always that things will improve. With menopause, the one thing that I worry about is that for some people in menopause, they're put on, if they've had a hysterectomy, they're put on estrogen alone, which unfortunately can stimulate. If people have a significant amount of endometriosis, even in menopause, we can stimulate it. When a provider is trying to do something helpful and manage menopausal symptoms. And so we always have to just be thoughtful about, again, the whole person. I want people to have, bothersome vasomotor symptoms of menopause, but I also want to make sure that we're being safe and that we're thinking about people's pain and what we might do to that when we do things like estrogen alone.
And just because you're in a low estrogen state doesn't mean that the other things that come along with endometriosis go away immediately either. So pelvic floor dysfunction is not going to go away immediately. The mental health conditions that come along with endometriosis are not going to go away immediately. Interstitial cystitis, IBS, those are still going to be around. So there's still a lot of symptom management, even if the estrogen level is quite low and the endometriosis may not be hormonal these studies are, they're biased. You know, there's a lot of people with endometriosis who never make it to an incisional surgeon. So if you have endometriosis and you've had fulguration or ablation, you know, you probably have persistent disease as opposed to recurrent disease. But how many people are out there who have never had surgery? Is their endo getting better or worse, staying the same? We can make a guess, but we can't tell you definitively.
And the other thing that's really challenging is the studies are very clear that we're bad at telling what is and is not endometriosis. So I think, pretty much everyone can look at what's like a classic gunpowder lesion and be like, yes, that's endometriosis. But endometriosis can also look kind of pink and fluffy. It can be a clear vesicle, it can look almost like a little bubble. It can look like, the lining of the abdomen should be nice and smooth and shiny. And if there's like this tiny like glaze of white, that can also be endometriosis. And so the problem with that is that ends up being a huge amount of space. And so if, my general rule of thumb is that if something doesn't look totally 100% normal, we should just take it out and send it to a pathologist. And a pathologist can look under a microscope and let me know what it is, because there's not really an additional risk to taking that tissue out. But it would be very, very hard if you're not looking for that to find it, and that if you're using ablation, very challenging to treat all of the different places that might look a little unusual.
And that can mean too that on the day of surgery we tell you we removed 17 specimens. If pathology only brings 9 of them back with endometriosis, we can't tell you definitively what your stage is on the day of surgery. We have to wait for pathology to come back. That doesn't mean that endo is less severe or less bad than it was on the day that you went into the OR. The stage has 0 correlation with your symptoms. It is merely a communication tool between us.
Yes, no, and people can have, if we talk about volume of disease, low volume and have horrible pain. And like I said, people can have stage 4 and have no symptoms at all. And I wish I could tell you why that was, but we just don't know. There have been studies looking at different brain structures and how we may upregulate or downregulate pain signals. But at the end of the day, there's a lot about pain and about endometriosis that we just don't know. And unfortunately, gynecology suffers from being one of the least funded specialties. And so we're really happy that there is more and more interest in this, and we are getting more funding for more studies, but we're just unfortunately behind in a lot of ways, and hopefully that will change.
Is it generally recommended to have patients take progesterone after surgery to prevent future reoccurrence?
That depends a lot on the patient. Patients with endometriosis have sometimes greater resistance to progesterone, so they may need a higher dose than people who don't have endometriosis. But some people don't tolerate that. And if your doctor is telling you you need to take a medicine that you don't tolerate, then that's not the right plan for you. So it really does weigh into risks and benefits. Is it better for you as an individual on these medications or your symptoms lower, versus is it better to be on them?
And that's true for all treatment in endometriosis, is that it is not one size fits all. I have patients where the last thing we want is to have surgery, and that's okay. Then we focus on things that are non-surgical. And then I have patients where, like the patients they've tried 30 different types of hormonal contraception, different suppression agents, and they've had horrible side effects. And that person shouldn't be on it, and we should maximize non-hormone therapy. I think that, everything has its role, and it really depends on what an individual wants to do and what feels like it is helpful to them. And I completely agree. There's some data that, again, particularly for endometriomas, just because those are easier to track when we do research, that being on our hormonal suppression decreases the risk of recurrence. But that doesn't necessarily mean that that's the right medicine for you. And that's true for all chronic pain, is that not every medicine is right for every person, and some side effects for some people it's just not worth it. And so, yes, I totally agree. It really is finding the right thing for the right person at the right time.
And then the final question, I think maybe we can get a couple of different people's perspective on, is about nutrition. What's the best way to quickly replenish, rejuvenate low levels of vitamins and minerals
Chinese medicine, they talk a lot about eating seasonally, eating a variety of colors, eating warm cooked foods over cold and raw foods. So there's like general principles that can be good for people. I'm a huge fan of whole food supplements over chemical or synthetic varieties. I just think the body utilizes them a little bit better. So there's a couple good, big brands out there that are big in the whole food world. And then I don't know too much about IV vitamins, so I'm interested to hear what other people have to say.
I can go. When it comes to nutrition, one of the components that really helps for inflammation and for better digestion and just to lower the levels of estrogen that really affect with pain is fiber. Protein, the right proteins, the right fats, the omega-3. When it comes to fiber, right, we do understand that helps us to also with our bowel movements. That if that doesn't happen, everything hurts right in this area. Having not only the vegetables and the fruits, but also having the right hydration in the body helps with everything. When it comes to the vegetables and the fruits, of course, just eating them without being cooked is the best because that's when you're actually getting the most nutrition from those fruits and vegetables. But in general, I think a diet that is high in fiber, definitely high in good fats like the omega-3s, and anything that has to do with hydration, water, and protein definitely helps. It doesn't eliminate, but it helps and alleviates the symptoms of endometriosis.
Some of the research that I've seen, people can get some benefit from, they can get benefit from higher volumes of supplements. So there are some, unfortunately, most of the studies are on rats. So can we translate that? But high doses of vitamin C have been shown to limit adhesions. Okay, well, vitamin C is not that difficult on the body to process if you can't really get yourself to toxic levels. So could vitamin C around our surgery may be beneficial? So sometimes I agree that whole foods or getting it naturally is going to be the best way, but sometimes we need it in such high volumes that supplements may be a better option. And then I don't know, I unfortunately don't know anything about IV therapies either, so I can't speak to that if it's uptake is better through IV versus capsule supplement.
From a surgical standpoint, IV iron is probably one of the things that we prescribe most often because not everyone can tolerate oral iron. It can be hard on the system, it can be rough. IV B12 is another thing that we run into fairly frequently. When we talk about getting ready for surgery, we will often have most people stop their supplements about 2 weeks beforehand because there's not good data on how they interact with anesthesia in particular. And it turns out you really want to wake up after your surgery. So we recommend that other than a daily multivitamin, you stop your supplements for a few weeks beforehand to eliminate unforeseen interactions.
Unfortunately, supplements are not regulated by the FDA, and so what is on the bottle is not necessarily what is in the supplement, and so sometimes there's very nice data from primary studies, but they've done mass spec analysis on what they are feeding their rats, and so what they are giving is definitely that item. What is unfortunately in the bottles on the shelf, there have been studies where people have bought off the shelf and done a mass spec, and it is not always what is claimed to be in it, which is what I struggle with in terms of those recommendations, which is that there probably are things that would be helpful, but I just can't guarantee that anything that I recommend is actually what my patients are able to then access and take, and that puts us in a just a challenging place.
All right, so that takes us to the end of our questions from our perspective. We've got about 5 minutes. If anybody has any other questions, then we can try to go through a couple questions. So we've got, yep.
saying that the next thing I can feel it's coming back, and like I've taken like I've gone to PT, hormone therapy, things like that, worked on like my diet and everything, and now the surgeon's saying there's nothing they can do for me but take my ovaries and leave me in menopause at 22. Is that true? No. No. So if your endometriosis was ablated, there's certainly a good possibility that you may still have endometriosis in your body. If you take out your ovaries, that is not a guarantee that the endometriosis is going to go away. The endometriosis can actually produce its own estrogen to feed itself even without your ovaries. So there's a huge difference between seeing a doctor who tells you a hysterectomy is going to be the definitive cure for your endometriosis versus a doctor who has advanced training and can actually treat it.
Poor Dr. Perez has heard me, our office is often an angry place.
A lot of feelings.
Yes, and I had a lot of feelings watching this documentary as well. But
Please don't take out a second mortgage for your surgery. We take insurance.
But and like I said, like everybody's care is individualized, and so there are always exceptions. But in general, true treatment of endometriosis from a surgical standpoint tends to be a decision. There are times where a hysterectomy is helpful for a variety of reasons, like in the documentary. Sometimes people have adenomyosis, so sometimes there are certainly indications. In general, a hysterectomy is not going to be the thing that actually treats the endometriosis, though sometimes it can be helpful in some situations. And the same with taking out an ovary where someone has had, endometrioma after endometrioma, and it's a really damaged ovary. There certainly are circumstances. I won't sit here and say that I've never taken out anyone's ovaries, because that would not be true. But in general, as a rule of thumb, I tend to recommend, like Dr. Burns, that we not take out the ovaries because now somebody is not in a menopausal age, but we have made them surgically menopausal, and so we put them at risk for osteoporosis, coronary artery disease, congestive heart failure, increased risk of anxiety and depression. There's some increased data coming out that estrogen plays a productive role for our brain in terms of exactly cognitive decline. And so we sort of have now opened this door to all these other things. And so then what we do, we put them back on hormones, like your ovaries were there, which doesn't make a ton of, from a physiologic standpoint, doesn't make a ton of sense to take out your ovaries and then put you on the same hormones that your ovaries make. And so, like I said, I'm not going to say that there's not certain circumstances in which all of us would do those things. But as a rule, I tend to not do that.
And that answer is somewhat different in the transgender community where patients are on testosterone because they will have a sex steroid in their body to help protect bones, heart, brain. But in the cisgendered population, taking out your ovaries at 22 is a very risky thing and is something that a patient needs to truly have informed consent, and that means knowing the risks and benefits. Ultimately, it's your decision. Would I recommend it? No.
So I got it's two in one story. I just had my fourth surgery in January. I'm having this surgery on the 8th. It's very exploratory. I'm a Dr. House patient basically right now. I'm on my 13th round of antibiotics. And my uterus hates me. There's an infection in there. It's a long story, but anyways, we are curious and going in just to see, we're considering, I can't say those.
Adenomyosis?
Can that ever turn, can that present infection-like, or does it ever infection-like, or would that then just be PID?
I've not seen an infection from adenomyosis,
But there is unfortunately, again, I think there's probably a lot that we still just don't know, to your point.
And so during the oral surgery, they had found endometriosis. All of my appendix was going hand for hand to the colon. And they were considering like a general surgery doing a consult and stuff. They were going back and forth, but because it wasn't necessarily a verge and consents and stuff, and just like they basically were like, well, we came in here doing what we knew we thought we were going to do. Let's pause. Let's wait. Let's see. Since then, why is everything? And since then, my life has been very unwell. Seeing some 13 and I had this thought and theory with the endometriosis all over the appendix. I guess, what have you seen or symptom-wise with patients with endometriosis on their appendix? Because I've been hearing like my appendix might be acting like it's an appendicitis, but not.
That
And maybe
can-
that's why, but there's still many other uterine cervical things that are presenting.
Yeah, that can definitely happen. Inflammation of the appendix, whether it's endometriosis or appendicitis, can present very similarly. One thing that we do know is that patients that have endometriosis on their appendix do have a significantly increased chance of developing carcinoma of the appendix. So the recommendation is that we remove the appendix anytime there is endometriosis on it.
And there's some newer data, there was the study that won the award at the conference this year, that if you have a right-sided endometrioma, the likelihood of having appendiceal endometriosis is extremely high. And one of the recommendations that have been kind of been tossed around is, should we, in people who have endometriomas, should we be doing prophylactic, just taking out their appendix prophylactically? And I think that is
So I'm still.
unclear what we should do, but that has been an ongoing conversation.
It is important to note that not all gynecologists are trained in performing appendectomies.
Yes. And like, I love my surgeon, I'm a special EKG is, I do, but I still battle with that. And now the general surgeon did it, it's not available on surgery day, but in the terms that that's what I have to go in for now, maybe it's not the best time for someone either, but maybe it'll present itself and maybe I'll pick up the ladder. Thanks for asking.
You know, if I have someone that I know has endometriosis on their appendix, I'm going to do a lot of investigation on the bowel to see, do I need to have a colorectal surgeon available for potential resection of bowel endometriosis? Because there's a significantly high likelihood that it's in both places. If it's on just one portion of the bowel, it is probably not, there's not a little ball there that sits around your appendix and says, we're only going to be here.
And it's most likely to be on the same way. And so by the time it's, to your point, it's on the appendix, then my antenna is up, that is it somewhere else too.
Thank you. And then we'll take one last.
So I am in my 5th year PA school, which I'm very excited about. It has been a very strenuous journey having endometriosis while also being in medical school, basically, and having to convince, I'm in a 5-year program at RIT, so I'm in a very accelerated program. There's not a lot of wiggle room for extra stress outside of school, and anything beyond school I feel like is not tolerated well by any of my professors. And even now, starting rotations, I'm finding it also mentally challenging to know when it's appropriate to stop what I'm doing to take care of my body, just out of fear of not being perceived as a good enough student, if that makes sense. And so just from your perspective, how, or anyone, how do you recommend I move forward in terms of, I have a therapist, but you're better with that. How do I manage those relationships with my professors and just
number of hours that you're expected to be on your feet and you're expected to be running at 110%. It's a very real thing. It's a very hard thing. With people who have invisible illnesses, it can be particularly difficult because medical professionals are expected to be superhuman. We come to work sick because we have patients, and that's a sacrifice that we knew we were making when we went into the field. Is that wise? No. Is that recommended? No. If I had to go back and do it all over again, would I have maybe stayed home from school with pneumonia? Probably. Would I go to school with pneumonia? Definitely. It is only in the last maybe 5-10 years that it has become more acceptable to advocate for yourself within medical education, and that has been a very positive thing for trainees. But you're still going to run into people that aren't going to understand. The best way that you can present your case is by giving the facts. And if that means that you need a doctor's note saying specifically, like, these are the things that are reasonable and these are appropriate accommodations, then that's what you need to do. Because you're going to run into a lot of people that don't know what endometriosis is, and they're going to go on the internet and they're going to say, oh, your periods suck. And that's not endometriosis. That is a small-minded and a closed-minded opinion. But having an actual, these are the facts, this is the data. You're going to earn respect from doing your research, presenting evidence-based medicine, and advocating for something that people can't see from the surface.
I want to add something because I wrote multiple letters to my clients. So unfortunately, go to your PCP, like your primary doctor, as much as you need, and start to ask a letter for the symptoms because they don't understand the disease. They just say, okay, this client cannot stand more than 5 hours a day. So do more like the symptoms for the mental health and the physical aspect of the symptoms itself. Don't go to, I'm going to give you education on right now that they don't get care for that. In school, they care for the symptoms. So I did. I know, I'm just saying, I wrote many letters in the last, I would say, 9 years for client just symptom management. That's diagnosed. I do mental health. I don't even give them, and people don't know, but they know depression. So I just said, this client is depressed. This is what I recommend. People take it very seriously if you write like that. So make it more black and white. Don't go to don't go deeper, and make it very, it's for school. This is not the kid life. So I would make it for like employers, school, a lot of symptom management. So mental health and also